Is is he has infective endocarditis, but he underwent a valve replacement 1 year ago, taking warfarin. Now there is rhythm with crisp mechanical valve. Mm, There is 3 plus blood. Is it because of warfarin? Okay, wait. Warfarin underwent. There is no cause. Nothing is present. Intermittent dark urine. I was thinking. Okay, evaluation of red urine. Evaluation of red urine. If there is red or brown urine or heme positive dipstick urine analysis. If urine analysis show 3 plus 3 or more than 3 RBC, it is hematuria. If 0 to 2 RBC hemoglobinuria, intravascular hemolysis and decrease hemoglobin and heptoglobin, and myoglobinuria or rhabdomyolysis increase CK. This patient with dark urine has heme positivity. This patient with dark urine has heme positivity on urine dipstick, but few urinary red blood cell. But urinary red blood cell occur in myoglobinuria and hemoglobinuria in the absence of muscle leg rhabdomyolysis. This patient with mechanical aortic valve has hemoglobinuria. 3 plus 7 hemoglobinuria, a condition of free hemoglobin in the urine. Increased turbulence through the prosthetic valve can cause shearing of RBC, which can cause intravascular hemolysis and release of free hemoglobin. Hemoglobinuria occurs when free hemoglobin exceeds both the saturation of the serum haptoglobin and the resorptive capacity of the proximal tubule. The result is urine. The result in urine that is red hemoglobin pigment or brown methemoglobin pigmentation with detection of heme positive blood on urine dipstick, but with only 0 to 2 RBC in the urine, which is normal and considered negative, in contrast to hematuria, 3 or more than 3 RBC on high power field. The next step in evaluation of this pediatric patient with suspected hemolysis is complete blood count to confirm to complete blood is a complete blood count to confirm the presence of and thus assess the severity of anemia, which is likely the cause of patient's exertional fatigue. Additional findings of mechanical intravascular hemolysis include low heptoglobin, elevated LDH, increased reticulocyte count, and schistocyte on peripheral blood sphere. So we are looking for anemia. That's why CBC. So if there is more than 3 RBC, it is hematuria. Okay, then CBC. Okay, can you hear me? Oh, yes. Huh, yes. I'm seeing you are watching Den of Thieves. Okay. What's his story? Because I have like I am out of patience while I'm watching the series on this. What I do, I see the first episode and I see the last episode, and then then the rest of the thing I try to imagine. Violence. Oh, okay, okay, okay. So manage. So management. Should I read the box first? Okay. Management of symptomatic ureteral stone. Management of symptomatic ureteral stone. Initial symptom control. Analgesic, analgesic, antiemetic, and IV fluid. Analgesic, antiemetic, and IV fluid. Assess the following: UTI, AKI, complete obstruction, anuria, and intractable pain. Complete obstruction, anuria, and intractable pain. Nausea, vomiting. Outpatient management. Uh, if there is no UTI, no AKI, there is no complete obstruction or no intractable pain, nausea, vomiting, then outpatient management, pain control, oral hydration, alpha blocker. If stone is more than 5 millimeter, and less than 10 millimeter, and strain urine. Outpatient urology consultation, if stone is more than 10 millimeter, no stone passage in 4 to 6 weeks and persistent gain. Inpatient management, urgent urology consultation, IV medication, analgesic, IV fluid, antibiotic, alpha blocker. If stone is more than 5 millimeter and less than 10 millimeter, and strain urine. Okay, this patient has acute flank pain and nausea due to urolithiasis, and CT scan reveals 4 millimeter stone. There are no signs of urinary infection. There are no signs of urinary infection, fever, pyuria. Renal function is normal. Pain and nausea are well controlled following administration of the analgesic and antiemetic. This presentation is consistent with an uncomplicated ureteral stone and can be managed conservatively at home. Most ureteral stone less than 5 millimeter in diameter, lo- m- most ureteral stone less than 5 millimeter in diameter pass spontaneously. Oral analgesic NSAID are typically prescribed, and increase oral fluid intake more than 2 to 2.5 liter per day and is advised to ensure adequate flow of dilute urine. In addition, patients are instructed to strain their urine so that a stone can be captured, so that the stone can be captured for composition analysis, composition effects, recommendation for future stone prevention. How people can strain their urine, I don't know. For larger stone, more for larger stone more than 5 to less than 10 millimeter, alpha blocker tamsulosin may help facilitate passage. In contrast, stones more than 10 millimeter are likely to pass spontaneously and may warrant outpatient urologic evaluation to consider additional intervention lithotripsy. Regardless of stone size, urgent urology consultation and hospitalization are indicated for patients with signs of urinary infection or sepsis, aka complete obstruction anuria, or refractory pain, nausea, or vomiting. Okay, okay. We'll look at the box first. Yes, That one is just if more than 3 plus RBC, then this, yes. If more than 3 RBC, that is hematuria. Now, if you find more than 3 RBC, that means hematuria, is it glomerular or is it non-glomerular? If it is glomerular, if it is glomerular origin, findings of glomerular disease include brown urine, edema, hypertension, proteinuria, and RBC-CAS, like nephritic syndrome. Then creatinine, complement level, and CBC. So if it is glomerular, then creatinine, complement level, and CBC. If it is non-glomerular, then is it symptomatic or is it asymptomatic? If it is symptomatic, like trauma history, then CT scan of the abdomen. If UTI, dysuria, pyorrhea, then urine culture antibiotic. Is it perennial or meatal irritation? Reassurance. Is it kidney stones, flank pain, crystal, renal ultrasonography? And if it is asymptomatic, renal ultrasonography, urine culture, and urine calcium, creatinine. So this patient is symptomatic, isn't it? Is it? But symptomatic. So non-glomerular. Yes, it is non-glomerular. I got it, but okay, no symptom then. Dysuria, frequency urgency. Yes. Okay. This patient has acute onset asymptomatic. This patient has acute onset asymptomatic gross hematuria with no history of trauma. Signs and symptoms of infection, dysuria, pyuria, leukocytosis, or evidence of glomerular disease, cast proteinuria, hypertension, common condition associated with isolated gross hematuria in children include meatal irritation. Meatal irritation which is painful and may be visible on external examination. And nephrolithiasis. Classic symptoms of nephrolithiasis, flank or abdominal pain, commonly occur in older children and adults as the stone passes through the urinary tract and obstruct the ureter. However, young children are more likely to have stones located in the kidney, which is painless and can cause atypical presentation of gross hematuria alone, as in this patient. Apart from confirming hematuria, urine dipstick positive for blood, red blood cell on microscopy, urine analysis may be otherwise unrevealing because characteristic crystals are not always present. Characteristic crystals are not always present. A major risk factor for nephrolithiasis is hypercalciuria, which may be suspected because of a previous history of microscopic hematuria and confirmed with a spot urine elevated spot urine calcium creatinine ratio. Okay. Okay, sorry, I haven't seen that. Okay. The preferred imaging study for suspected nephrolithiasis is renal and bladder ultrasonography, which can detect some stones and ureteral obstruction while avoiding radiation exposure. Ultrasonography is also initial imaging study of choice for excluding less common but a serious cause of non-glomerular hematuria, such as a renal mass Wilms tumor, a condition usually associated with abdominal mass swelling. If ultrasonography is non-diagnostic, CT scan of the abdomen without contrast may be required because it is more sensitive for identifying small calculi. Okay, okay. Asymptomatic bacterial and pregnancy. Okay, okay, I'm reading. Wait. Uh, this patient has asymptomatic bacteriuria. This patient has asymptomatic bacteriuria. The growth more than 10 to the power 5 colony forming unit per ml of a single bacteria in a clean cat urine specimen from a patient with no urinary tract infection symptom, dysuria, urinary frequency. In pregnancy, increased progesterone level cause smooth muscle relaxation and ureteral dilation. Because of these physiologic changes, pregnant women with untreated asymptomatic bacteria are increased risk for acute pyelonephritis, and subsequent complications include acute respiratory distress syndrome and premature labor and delivery. Because of risk for pyelonephritis in pregnancy, all women require urine culture screening for asymptomatic bacteria is initial visit. The most common associated pathogen is E. coli, as in this patient. Pregnant women with asymptomatic bacteria require antibiotic therapy. The first line is phosphomycin and beta-lactam. As a test of cure, a repeat urine culture is performed after antibiotic treatment due to risk for persistent or recurrent bacteria. Okay. Yes, I'm thinking extremely sorry because renal gives us heart attack. Oh, okay. This older patient with voiding symptoms. This older patient voiding symptom dysuria, frequency, hematuria, acute right-sided flank pain, hydronephrosis. Hydronephrosis in the absence of nephrolithiasis are are concerning for bladder cancer. In the United States, most patients arise from bladder surface epithelium urothelium due to chronic exposure to chemical carcinogen in the environment or in cigarette smoke. Older adults are the most often affected, typically have one of the following. Hematuria, tumor growth factor drives the formation of new blood that may bleed. Tumor growth derives the formation of a new blood vessel that may bleed, leading to gross or microscopic hematuria. It is classically present throughout the voiding and not associated with painful voiding. Hydronephrosis. Hydronephrosis, bladder outlet or ureter obstruction by the tumor, leads to hydronephrosis, which can be associated with flank pain, acute kidney insufficiency, elevated creatinine as seen in this patient. Bladder cancer can cause unilateral hydronephrosis, obstruction of the ureteral orifice, or bilateral hydronephrosis, obstruction of the urethral orifice. Voiding symptom, bladder tumors can reduce the bladder capacity. Bladder tumor can reduce the bladder capacity, can cause detrusor muscle hyperactivity, or result in bladder, neck, or urethra obstruction leading to voiding manifestation such as nocturia, frequency, urgency, dysuria. Adults age more than 40 who have unexplained hematuria with no evidence of infection, pyuria, or bacteriuria. Glomerulonephritis, red blood cell casts, dysmorphic red cell, or nephrolithiasis require investigation for bladder cancer. The gold standard is urine cystoscopy, which allows direct visualization of the bladder wall and biopsy of the suspicious mass. Okay. Normal 135 to 145. Yes. Low. Chloride is low, is high. So, alkalosis, uh, metabolic alkalosis. It is alkalosis, which is metabolic, isn't it? Metabolic alkalosis, like pH is high, Bicarb is high. Uh, Metabolic alkalosis with hypokalemia. Hypokalemic. Hypokalemic, hypochloremic, metabolic alkalosis. Hypokalemic, hypochloremic, metabolic alkalosis. Uh, Hypokalemic, hypochloremic, metabolic alkalosis. Self-induced vomiting. Oh, okay. If you find metabolic alkalosis, if you find metabolic alkalosis, pH more than 7.45 and bicarb more than 24. pH more than 7.45 and bicarb more than 24, then we will do urine chloride. If urine chloride is low, less than 20, if urine chloride is low, less than 20, then it may be vomiting, nasogastric aspiration, diuretic overuse. Vomiting, nasogastric aspiration, and diuretic overuse. If it is high urine chloride, if it is high urine chloride, then we have to look for, is it hypervolemic or hypovolemic. If it is hypovolemic, then Bartter or Gitelman syndrome. If it is hypovolemic, it is Bartter and Gitelman. If it is hypervolemic, it may be excess mineralocorticoid activity, primary hyperaldosteronism, Cushing syndrome, ectopic SATH production. This patient pH is more than 7.45, bicarbonate is more than 24, consistent with metabolic alkalosis. Measuring urine chloride can be helpful in the diagnosis of the metabolic alkalosis adequate adequate chloride delivery distal to the renal tubule, adequate okay, because adequate chloride delivery distal to the renal tubule is necessary to excrete bicarbonate, which means that the total body chloride depletion often plays an important role in the initiation and the maintenance of metabolic alkalosis. Etiologies of metabolic alkalosis that involves total body chloride deposition are characterized by hypovolemia and will demonstrate low urine chloride, less than 20 milliequivalent per liter, more than 20 milliequivalent per liter. Okay. Mm, where okay, etiologies of the metabolic alkalosis that involve total body chloride depletion are characterized by hypovolemia, will demonstrate total low urine chloride less than 20. These type of metabolic alkalosis are considered as saline responsive because repletion of chloride with normal saline um, will normalize renal bicarbonate excretion and correct the alkalosis. Such etiologies include nasogastric suction or severe vomiting, which involves a loss of hydrogen and chloride, hydrochloric acid from the stomach, a loop or thiazide diuretic overuse, which involve loss of chloride and retention of bicarbonate by the kidney, eventually leading to total body chloride depletion as well as hypovolemia Of note, although these patients are overall chloride depleted, urine chloride may be high in the setting of recent diuretic injection within the several hours of the measurement. Etiologies of the metabolic alkalosis in the absence of chloride depletion include conditions of the mineralocorticoid excess such as primary hyperaldosteronism. These patients are typically hypervolemic, and the metabolic alkalosis is driven by aldosterone mediated hydrogen loss from the kidney. High urine chloride more than 20 is present, and the metabolic alkalosis does not correct with chloride repletion. Saline unresponsive. Autosomal recessive renal tubular channelopathies represent a special case. Bartter syndrome mimics loop diuretic overuse, and Gitelman mimics thiazide diuretics overuse. Although affected patients are chloride depleted, although affected patients are chloride depleted and high urine chloride is present in the defect, high urine chloride is present in the defect persistently impairs the chloride reabsorption. The metabolic alkalosis the metabolic alkalosis does not correct with chloride repletion. Okay, I am lost maybe. So it is easy. It is easy. Like think if you find a metabolic alkalosis, I know the box, but I actually when I deal the question, I actually forget the box. But I have studied this box. Yes. Are you looking for the mechanism? Barter and Gitelman, they are Barter actually blocks sodium potassium 2 chloride channel in the uh, loop of Henle, in the actually loop of Henle, sodium potassium and 2 chloride channel. So it is actually blocking the chloride channel. So as it is blocking the chloride channel, so this chloride is unable to this chloride is in the blood, and when it is excreted through the kidney, then urine chloride may be high. Barter and Gitelman both Barter blocks the sodium potassium 2 chloride channel, and Gitelman actually blocks sodium chloride channel in the where in the sodium wait DCT, in the early DCT. So both blocks the sodium chloride channel. So chloride remains in the blood when it excreted through the kidney. Then urine chloride is high. If you uh, if you try to remember in that way, and Barter actually blocks the mechanism of frusamide, and Gitelman actually blocks the uh, Gitelman actually like takes the thiazide's property. Like think in that way. Like if somebody is taking frusamide all the time, what will happen? It is Bartter syndrome. And if somebody is taking thiazide diuretics all the time, then what will happen? That is uh, what can I say? Gitelman syndrome. Okay, you say. Yes, it is in the first aid. You open the first aid. I am I make you study the first aid, or I will open the first aid. We whatever you want. Okay, I'm sharing my screen now. Okay, wait. Oh, can you see my screen now? Probably yes. Okay, this is the nephron transport physiology. This is the nephron transport physiology. Uh, in thick ascending limb of lobar family. If you want to from if okay, I am making you study of everything. Okay, if we in nephron transport physiology in PCT proximal convoluted tubule, in proximal convoluted tubule it contains the brush border and it reabsorbs these proximal convoluted tubule actually reabsorbs. Oh, wait. Mm, this this proximal convoluted tubule actually reabsorbs everything like glucose, amino acid, everything. Most bicarbonate, chloride, phosphate, potassium, uric acid. So it actually reabsorbs everything. And this reabsorption happens via different channel like sodium glucose co-transporter in here. Got it? Sodium glucose co-transporter. So this sodium glucose co-transporter can be blocked by SGLT2 inhibitor like canagliflozin, dapagliflozin, empagliflozin. Okay, and again there is another channel like sodium hydrogen counter transport pump where sodium is entered into the PCT and reabsorbed here and hydrogen is getting out. This hydrogen actually binds with the bicarbonate and forming carbonic acid, and then it becomes dissociated into carbon dioxide and water, and this water then again reabsorbed in the PCT. And in here there is chloride reabsorption, so everybody is reabsorbed in the PCT. Got it? Okay, so in here none of the diuretics work in here, only the acetazolamide, works in here like acetazolamide helps in dissociation of carbonic acid into carbon dioxide and water. Then this water enter into the PCT, and then this water again binds with the carbon dioxide and form carbonic acid, and then it becomes dissociated. Okay, this acetazolamide only works in PCT. Okay, now so most of the solute reabsorption happens in the proximal convoluted tubule. Okay, now thin ascending limb of Lupafel. It is just it is nothing. Like it is an insignificant channel. Like thin descending limb of Lupafenley, it makes the urine hypertonic. It is only the concentrating segment. So it what it does, it passively reabsorbs the water. So it soak out the water and makes the inner solute hypertonic. Got it? Now the main part, thick ascending limb of loop of Henle, the dull, thick ascending limb of loop of Henle actually blocks sodium, potassium. It works via this channel, sodium, potassium 2 chloride channel, what I was talking about. So this channel can be blocked by loop diuretics. So sodium is unable to reabsorb potassium and chloride is unable to reabsorb. So it is present in the apical membrane and it passes through the urine. You have seen in here, like this part is in the urine, this part is in the blood. So as it is unable to reabsorb, in the tal, like thick ascending limb of loop of Henle. So it will pass through the urine. Got it? Okay. So again, the potassium is getting out through these potential energy potentials. Okay. And there is so thick ascending limb of loop of Henle actually reabsorbs sodium, potassium, and chloride. If there is blocker, so it is unable to reabsorb and it is excreted through the urine. So indirectly paracellular reabsorption. Again, there is another mechanism like paracellular reabsorption of the magnesium and the calcium through the lumen potential gradient generated by the potassium. This point is very important. Why? There is a channel called ROM. I actually forgot this ROM channel. So think in that way. If somebody has hypokalemia and you are unable to correct the hypokalemia, even if you are giving lots of potassium, then what you will do? Then you will see that if there is deficiency of magnesium or calcium, if there is hypomagnesemia or if there is hypocalcemia, so when there is hypomagnesemia, hypocalcemia, it disturbs the potassium to correct. So you need to correct the magnesium and calcium first, then you can correct the hypokalemia. Because of this uh, uh, because of this phenomenon, like this ROM channel, because of this channel, like this paracellular reabsorption of magnesium and calcium through the positive lumen potential, it is which is generated by the potassium. So if magnesium and calcium is absent, so these potassium will not gonna correct. You will find this type of question too. Okay, this portion is impermeable to water, so there is no water is getting out. So the solute it it makes your urine or our urine less concentrated, and in here 10 to 20% sodium is reabsorbed. So furosemide, like loop diuretics work through this pathway, and Bartter syndrome actually uh, means the continuous loop diuretics. Okay, you will see the Bartter syndrome in the later part. Okay, now the early DCT. In the early DCT, I have told you that there is sodium chloride channel. This sodium chloride channel is blocked via these thiazide diuretics. So early DCT reabsorbs sodium and chloride. It is also impermeable to water. It makes our urine fully dilute, hypotonic urine. So thiazide diuretics works here. So if sodium and calcium is not reabsorbed in the DCT, so what will they do? They will pass through the kidney and they will come out through the urine. Okay, and another important part is PTH, parathyroid hormone. Parathyroid hormone actually increase calcium sodium exchanger in here, parathyroid calcium sodium exchanger, like sodium is entering in the DCT and calcium is going to the basolateral membrane for reabsorption. So in here increase calcium reabsorption through this calcium sodium exchange. And PTH works in PCT2. PTH actually inhibits sodium phosphate transport in here, so more and more phosphate excretion happens. And finally, the collecting tubule and the collecting duct. Collecting tubule actually reabsorbs sodium. It reabsorbs sodium in here. It reabsorbs sodium for secreting hydrogen and potassium regulated by the aldosterone. So, so it reabsorbs. Sorry. Okay. So collecting tubule actually works in here. So this channel can be blocked by this sodium channel can be blocked by this to a drug like amiloride and trimethoprim, and actually spironolactone works in here. Like spironolactone block the INAC channel. Uh, Look in here, it is written like aldosterone also acts on mineralocorticoid receptor mRNA protein synthesis in the principal cell, like increase apical potassium conductance, increase potassium sodium potassium pump, increase sodium potassium pump. In here there is increased sodium potassium pump and increase INAC epithelial sodium channel activity and lumen negativity potassium secretion. In alpha intercalated cell increase hydrogen potassium ATPase activity, so there is hydrogen secretion, increase bicarbonate and chloride exchanger activity. And in here, like V2 for tubule ADH receptor works via this V2 receptor. Insertion of the aquaporin or water channels on the apical side. Okay, now the Barter and the Gitelman. Look in here, this is Barter, this is Gitelman. What is Barter? Barter is reabsorption defect in the thick ascending limb of loop of Henle. That means it is actually Barter syndrome, means like Barter is the blocker of the sodium potassium 2 chloride channel. Like Barter is works like chronic loop diuretics. Now you got it. Barter is like works as a chronic loop diuretic. So what will happen in Barter syndrome? In Barter syndrome, there will be metabolic alkalosis. We have found that in Barter syndrome, there is metabolic alkalosis. So there is hypokalemia, hypochloremia. There is hypochloremia, hypokalemia, and hypercalciuria. Got it? And it is autosomal recessive. And Gitelman is just like the chronic thiazide diuretics. It causes reabsorption defect in the sodium chloride in the DCT. So there is metabolic alkalosis, there is hypokalemia, hypomagnesemia, and hypochloremia. It is also autosomal recessive. And this too is there are other syndrome too. So Barter works here, thick ascending limb of loop of Henle. Gitelman works here. Okay, okay. And sorry, yes, you can tell me. Thiazide. Oh, okay. What are okay? You can, if you want the mnemonic, there is mnemonic. Okay. Now the drugs. You understand the pathophysiology? Okay. Now, okay. In the last part, like there are some small, not all is covered through this mnemonic, but most of them is covered by the mnemonic. Okay. Oh, why? What is happening? Wait, my pen is getting crazy. Okay, wait one sec. Oh, okay, now look here. Okay, if you wish to remember, then you can remember. Like in loop diuretics, there is ODANG, like autotoxicity, hypokalemia, hypomagnesemia, and there is dehydration, allergy, metabolic alkalosis, and nephritis and gout. And another thing you have to remember, like loop loses calcium. I have told you plenty of time. Like loop loses calcium. So there is Hypokalemia, there is hypocalcemia, there is hypomagnesemia in loop diuretics. Got it? Okay. Then the thiazide, thiazide is hypergluc. The thiazide is hypergluc, like hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, glycemia, lipidemia, uricemia, and calcemia. And another thing like hypokalemic, hypochloremic, sorry, hypocalemic metabolic alkalosis. There is hyponatremia also. Both thiazide and loop, there is hypokalemic metabolic alkalosis. Okay. So this is ODANG and this is hypergluc along with this. And the other two like potassium sparing spironolactone, eprilone, amiloride, and triamcinolone. Okay. There is no mnemonic here. AC inhibitor, you don't need the mnemonic to remember AC inhibitor. Okay. Sorry. How ACTH causing low chloride in the urine? Mm, ACTH causing high chloride in urine, isn't it? ACTH, what actually ACTH does? ACTH actually acts on the adrenal cortex, so it actually stimulating the glucocorticoid production. Okay, so cortisol at high level can cortisol at high level has mineralocorticoid effect, especially when it overwhelms. Like there is another syndrome called same. Okay, I am coming in the later part. This like cortisol at high level acts cortisol at high level acts like mineralocorticoid effect. So as it is giving the mineralocorticoid effect, what does the mineralocorticoid does? It causes sodium reabsorption and hydrogen excretion, isn't it? Like aldosterone is doing. Okay, like so it is what it is doing. It is retaining sodium and excreting the chloride. Okay, what then happens? Like chloride actually follows the sodium. To maintain this electroneutrality, sodium is reabsorbed and chloride may be excreted in the urine depending on the segment of the nephron and the ion transporter involved. Got my point? So okay, I am okay. I am explaining again. Okay, what actually ACTH does? ACTH stimulates cortisol. You got this point, isn't it? And cortisol at high level acts at high level can have mineralocorticoid effect. Okay, so this can lead to increased sodium reabsorption as it has mineralocorticoid effect. It can increase sodium reabsorption and potassium and hydrogen excretion like aldosterone is doing. Got it? Yes. So what then happens? Like chloride follows the sodium. Why chloride following the sodium? To maintain the electroneutrality. Sodium goes with the chloride. Sodium is positive charge, chloride is negative charge. So maintaining the electroneutrality. As sodium is reabsorbed, chloride may be excreted in the urine depending on the segment of the nephron, and the ion transporter involved. Okay, and uh, and if bicarbonate is retained, like if there is alkalosis, chloride may be excreted to balance the charge. Got my point? So it is actually like for the charge neutralization, it is happening. Like sodium is reabsorbing and chloride is following the sodium to neutralize that condition. That's why sodium is reabsorbing and chloride is excreting. So thus electroneutrality is maintained. Got it? Excreted. Chloride is excreting. So as chloride is excreting, so there is ion in chloride. I can see your screen. What is happening? Wait. Okay, now. Is it varicose vein? Yes. This patient with this patient with membranous nephropathy, a common cause of nephrotic syndrome. Common cause of nephrotic syndrome shows evidence of an acute renal vein thrombosis, occlusion of the left renal vein markedly increases glomerular pressure and causes hematuria and left-sided flank pain because The left gonadal vein drains into the left renal vein. Obstruction also causes left gonadal vein dilatation. Risk factor of renal vein thrombosis include nephrotic syndrome, especially membranous nephropathy, renal malignancy, and trauma. Nephrotic syndrome, which is characterized by proteinuria more than 3.5 gram per day, hypoalbuminemia less than 3 gram per deciliter, peripheral edema, and hypercholesterolemia is also associated with hypercoagulability. As a consequence, patients who have nephrotic syndrome are at increased risk of DVT, pulmonary embolism, renal vein thrombosis. Patient with hypoalbuminemia can become Patient with hypoalbuminemia can become hypercoagulable as they also lose protein C, protein S, plasminogen, and antithrombin 3 in their urine. In addition, nephrotic syndrome is association with increased platelet activation and circulating level of fibrinogen among other hemostatic abnormalities. Patient with renal vein thrombosis and acute kidney injury undergo urgent clot removal, that is thrombolysis, and other anticoagulation is appropriate. Okay. Okay, patients with CKD are usually treated with RAS inhibitor lisinopril to slow progression of end-stage renal disease. However, a common complication in However, a common complication of this class of medication include, in the setting of CKD, is chronic or mild hyperkalemia. Patients with Although patients in medication in the hypercalcemia is treated with discontinuation of the offending medication, the benefit of RAS inhibitor is in patients with CKD generally outweighs the risk of chronic hyperkalemia. Therefore, the medication is usually continued and the hyperkalemia is treated separately. Urgent treatment: calcium gluconate, insulin plus glucose. Hyperkalemia is indicated. Hyperkalemia is indicated in the setting of hyperkalemic malignancy, which are marked by serum protein more than 6.5, rapid escalation in serum potassium during tissue breakdown or symptomatic hyperkalemia, ECG change, cardiac arrhythmia. Patients who do not have hyperkalemic malignancy, as in this patient with a moderate chronic elevation of the potassium and creatinine level that is baseline, do not require urgent treatment unless they have concomitant oliguria or end-stage renal disease. They are generally managed with low potassium diet, less than 40 to 70 milliequivalent per day, and avoidance of other medication NSAIDs that raise potassium. Patients also frequently receives an oral cation exchange agent, patiromer, zirconium cyclosilicate. These insoluble compounds bind potassium in the colon in exchange for calcium or sodium and are then excreted in the stool, thereby eliminating potassium from the body. Patients with CKD who are hypervolemic also sometimes receive a thiazide, hydrochlorothiazide, or loop furosemide, which increase the potassium excretion. Okay. Okay. This patient with symptomatic hyponatremia, most likely due to use of hypotonic, most likely due to use of hypotonic IV fluid, 0.45% saline, and 2 postoperative syndrome of an inappropriate antidiuretic hormone release, which is stimulated by pain, nausea, or stress. Low serum tonicity results in influx of the water into the brain cell, leading to swelling and cerebral edema. Symptoms reflect elevated intracranial pressure. Mild or moderate symptoms include nausea, malaise, headache, confusion, whereas severe symptoms include seizure, coma, respiratory arrest. Adaptation to normalize brain volume extrusion of osmolytes from brain cell take more than 48 hours. Acute hyponatremia present less than 48 hours is poorly tolerated, which are at high risk of brain herniation. Patients with serum sodium less than 130 may be with any symptoms of elevated ICP should be treated with hypertonic saline boluses to rapidly correct the sodium. Because neural adaptation have not occurred, patients are relatively low risk of osmotic demyelination syndrome. Chronic hyponatremia, that means presence more than 48 hours, and is typically better tolerated with the hypertonic saline, is often preserved for those with severe hyponatremia and severe symptoms, seizures, and concurrent intracranial pathology, masses, and severe stroke. Yes, patients with symptomatic hyponatremia require rapid correction of sodium levels to prevent herniation. This cannot be accomplished with isotonic saline 0.9% saline and lactated ringers, which slowly raise serum sodium. Additionally, the use of isotonic fluid in patients with SIADH will worsen hypernatremia. Okay. Okay, primary viewer. This patient with vesicoureteral reflux, a retrograde flow of urine in the upper urinary tract due to a congenitally shortened intravesical ureter. Normally, the intravesical portion of the ureter, the segment within the bladder wall, is compressed during bladder contraction, preventing urine from flowing into the ureter. Patients with shortened intravesical segment have incomplete ureteral compression, leading to retrograde flow. Viewer mm, typically presents with febrile UTI, febrile UTI typically presents with febrile urinary tract infection, hydronephrosis, or renal ultrasound is often present. Widings hysterostratigraphy can confirm the diagnosis. The patients with severe VUR have reflux into the ureter and kidney and is associated with structural damage, blunting of the calyces as seen in this patient. Retrograde urinary flow allows bacteria to ascend from the bladder into the kidney, increases the risk of pyelonephritis. Recurrent infection and inflammation can lead to renal scarring and chronic kidney disease. Therefore, prophylactic antibiotics are warranted, although antibiotics do not prevent the reflux. The urine flow to be sterile and limiting the risk for recurrent infection. In contrast, patients with mild fever have reflux into the ureter and possibly the collecting system with no associated renal damage. The risk for upper the risk for upper UTI correlates to fever severity, so that patients have lower risk of recurrent pyelonephritis. In addition, spontaneous resolution of the fever by age 5 is common due to growth of intravesical ureteral segment. Management is typically close monitoring with or without prophylactic antibiotic. Yes. Primary fever in children, retrograde urine flow through the short intravesical ureter, febrile UTI, renal ultrasound, hydronephrosis, voiding cystoureterectomy, ureteral filling with or without dilated or collecting system, mild, grade 1 to 2 observation with or without prophylactic antibiotic, severe grade 3 to 4 prophylactic antibiotics with or without surgery. Prognosis mild, spontaneous resolution with growth and severe renal scarring and CKD. Okay, okay, let's take a break. I feel like we have done plenty